good. Okay, welcome back everybody for our final Q&A session. We have several questions remaining from the morning sessions that we go through, and then in the afternoon also a number of questions already have been submitted. We start with questions that went through chat. Avram study 2015 evaluated the impact of post-op whole body scan on radioactive iodine administration decision. What is the value of pretext WBS in patients that already decision has been made to give them adjunctive therapy, considering high or intermediate risk of recurrence? Perhaps Dr. Bernet or Dr. Gulec or anybody else from the panel.
Well, I thought Douglas answered that. I'm teasing. Yeah, I mean, there's going to be controversy about this. I think there's low intermediate patients, I'm not sure that there's a benefit. In high risk patients or intermediate that's maybe high intermediate, if we want to divide them up, I think, you know, it may help you decide what kind of treatment, what kind of dose, and also maybe that you may find something where you're going to do follow-up anatomical imaging. So I would say I do a hybrid. I don't do pre-scanning on every intermediate patient. I kind of subdivide them, and some are young and healthy and don't have a lot going on, but they qualify as intermediate. And I don't do the pre-scanning, and then others I do. I don't know, again, if Markus or Doug want to weigh in.
Dr. Nostrand or Dr. Gulec or anybody else, would you like to provide further comments?
I can give my view real quick. This has been one of the most controversial issues, and in short, this issue is totally strictly dependent on the institutional protocol set. If you say, I'm going to do a diagnostic scan using this millicurie activity, and if I see this, I'll do this. If I don't see this, I'll do this. If I don't see anything, I won't treat. If you have a protocol set, then it may make sense. To me, say 1 millicurie diagnostic scan has a very low sensitivity. A negative 1 millicurie scan won't stop me doing treatment. Therefore, for me, it's a non-value added step. I stopped doing diagnostic scans. We only do 1 millicurie scans when we decide to do a dosimetry. It's an adequate dose for the dosimetry. Nothing I see or don't see would change my management and won't change my idea or plan to move forward with radioactive iodine treatment. That's the reason why I don't do it.
If I may comment, it's the same in our institution. We won't do it on a regular basis because we're aware of the false negatives and wouldn't base our final decision on a non-predictive scan.
And remember,
go ahead, Mike.
I was going to say, I'll let you talk about the scan stuff. Remember, the whole purpose of adjuvant therapy is you're treating a risk. You're not treating known disease. So we're treating a risk whether you see it on a diagnostic scan or not. Now, we routinely do diagnostic scans because our nuclear medicine guys like to do them, but they're I-123, 18 hours, just quick planar views. So they're, you know, unlikely to like find anything to change my approach. So I think if you're going to do diagnostic scans, it either ought to change your decision to treat or your administered activity. But when you're in that adjuvant therapy setting, unless it's going to change your administered activity, you're treating because of the risk and not necessarily because of disease that you find.
Yeah, at our facility, obviously, we do a lot of scans, and most get pre-therapy diagnostic scans. A key parameter for me, and there is not just the issue of false negatives, but we find information that alters management. And so I think Cesar summed it. If it's not going to change your management, that's a tautological argument, then whatever you find is not going to change your management. In testimony, humbly, we have routinely about 86 endocrinologists that refer to us routinely. And my testimony is that our staff, Dr. Garcia, Dr. Kulkarni, Dr. Asio, are delivering information that alters management. And that's our experience. And we've also published that in a group of 325 patients who were very selectively screened, that they were low risk, not even intermediate. So from our experience, and we've had this discussion with Vic and with Markus and you, Mike, there's a spectrum of viewpoints. And I think each facility has to decide, and they also need to assess the quality of the scans that they're getting. So we routinely do radioiodine pre-therapy scanning.
And Doug, along that same line, because we've talked about this a lot, I'm convinced my quick little I-123 scan is pretty unlikely to show me anything to change, right? How are you doing your diagnostic scans that you're getting, that sort of more degree of accuracy or sensitivity or whatever you guys call it?
Yeah, several comments. One, actually, you were the moderator. I presented some of the techniques that we use at the Boston meeting. I think that was in 1845, but I don't remember, but it wasn't that long ago. I think it was the World Thyroid Cancer Conference. But I've also have an article in Thyroid that I would refer attendees to that addressed, and I forget I think that was, you'd have to email me because I don't remember it wasn't that long ago, but it addressed radioiodine scans. Not all scans are created equal. And there's pinholes, and there's issues of spot views, of the longer imaging time. Markus showed a wonderful slide regarding detection, and that it isn't just activity, it's depth of the lesion, it's how long did you image, what's the technique that's used. It's delayed imaging to allow background to clear, and therefore you get better contrast. And this is nothing original with me. I mean, this is all published previously and just takes more time. That's the factor. And then some facilities go, I don't want to invest that time. But our experience and our techs are very good because they are also making these decisions that I see such and such, I do this. So our experience and humbly, our volume is huge. And it's elective. In other words, if they're not happy with the results, they're not going to, the endos docs aren't going to send to us. So I do think technique makes a difference, and that's not a reflection of people doing bad technique. It's just a decision of how that facility is doing it. A good example for me is I was at a previous meeting about 2 years ago before this COVID event, and every one of the images that were shown had a star artifact in the thyroid bed. Not one had a pinhole image to try to get around that star effect. That's an anecdote, but that's an example and an answer to your question.
Well, you said this is a totally elective scan. That's only if you do it on a withdrawal protocol. If you don't do a withdrawal protocol, it's not an elective scan. It's at best a semi-elective. And how do you coordinate with the subsequent treatment is another question. If you find something that's temporary, how do you really adjust if you are not using withdrawal protocol?
Well, again, I'm not sure what the operative word is, elective. I'm not sure it makes it elective, but
I mean,
yes,
we don't have all that time. We have a time schedule.
I just want to ask you, please, to be brief. We cannot spend more than 10 minutes answering one question. Just 2 more minutes and we have to go to the next question. I understand it's very controversial, but like Dr. Nostrand said in his talk, some controversy is good, correct? So maybe we should leave it there and just continue to other questions.
So should I respond?
Go ahead and answer, please.
Let's just give a short answer.
I don't know what elective means, but we'll discount that. Most of our patients actually get thyrogen. Now that raises a concern because of the cost, and it raises the concern for the logistics, but there's also, in a short answer, ways to manage that. And we have many questions of that sent to us, and I can even send out information on that, but the controversy will continue.
That's a very nice way to finish it. Thank you very much. So we go to the next question. Next questions, couple questions I addressed to Maria. One question is, what are your preferred agents in 1L and 2L, not sure exactly what it means, radioactive iodine refractory DTC, and what factors are considered when selecting and sequencing therapies?
Yeah, the 1L and 2L refers to first line and second line therapy.
Thank you.
So I always try and go with what's safest and has the least side effects as my first line. And then it also comes down to what can I get, you know, more easily for the patient. So I use a lot of very targeted therapy, right? So if we have the ability to give a selective inhibitor, that's what I do first. And I also weigh how, you know, the safety of giving an anti-angiogenic drug to certain patients, you know, patients who have very uncontrolled hypertension or already have a CKD, things like that. I look at that. And then the factors that I consider for selecting patients to sequence. Oh, no, I'm sorry. It's the factors considered when selecting and sequencing therapies, but also, is there a second question here?
Yeah, I thought maybe to you finish it and you can read the second question.
Okay, yeah, the second question.
Finish the first one.
It's, what is your approach in identifying and treating patients with specific tumor gene mutations? Do you test all patients? I think I kind of answered the first one. I essentially only test patients that I know are going to need systemic therapy. They're starting to get into trouble. And so I need a little bit of time, a little bit of lead time, because I've got to obtain the tumor, which is oftentimes outside, and then send it for molecular testing. And so I start warning the patient, we're going to start testing your tumor because you're going to need therapy. And so I try not to do it right when I need therapy, because then it takes a very long time.
I just want to make one comment. It's the same way like Dr. Van Nostrand said that sort of different scans are different. So I also just want to say that also different NGS tests are also different. I mean, in our lab, the full NGS panel is run in 5 to 6 days, not 3 weeks. So it's also, again, I mean, it obviously depends on the institution and the resources and everything, but they are not all are reported in 3 weeks, just for information.
Yeah, I'm going to start sending everything to you.
I'm not asking for this, you know, but yeah. Okay, very good. Then there is one more question regarding imaging technique. We find using the medium energy collimator for iodine 1, 2, 3 scans and high energy collimators for iodine 131 scans yield better images. What is the experience of the nukes in the panel on the selection of collimators with the isotope of iodine being used?
Markus, I've been talking. You want me to handle that, or do you want to handle that? That hand means sure.
Go ahead.
It's a good question. First of all, ideally, you'd like to use a high energy collimator for I-131. I admit that we do use sometimes a medium energy on I-131. We do not use a medium energy on I-123. We will use a technetium collimator for that. We won't go into the physics of it, but that's how we approach it. Now, part of the problem is when you are doing I-123 has distinct advantages over I-131, and it has distinct negatives, and I-131 has advantages over I-123 plus disadvantages. So it's a compromise. One of the most important things, though, for us in our technique is every patient gets a pinhole collimator image. When you go to national meetings, put this in the back of your mind, look at how many whole body images display star artifacts. And those star artifacts usually are interpreted, understandably with the whole body images, as residual thyroid tissue, remnant thyroid tissue. When you do pinhole images, you will start to see multiple focal areas of activity. And we've done studies of our surgeons who are excellent, very high volume surgeons, and rarely do we see more than 4 foci. So just the number of foci that we see with a pinhole, and a pinhole offers the highest resolution of any collimator for I-131. That's the way we look at it. And I hope that answers the attendee's question. I welcome Markus to comment on that.
Dr. Luster.
Just a question to you, Doug. Do you do that in every single patient, only if star artifacts are really apparent?
Everyone that shows any activity, it's automatic, yes. Now, if we see on the spot image or the whole body image that the next negative, of which we had 3 to 4% of those, we do not do a pinhole on that patient. But everyone else, it's automatic. Now, the downside of that, that's extra time and on the demand of the clinic. But our information that we obtain from that, to us, alters our management. Tautologically, if one automatically says, I'm doing A regardless of what I'm seeing, then of course, what you're doing, that imaging study will have no value. That's not because the study has no value. It's because the previous decision has been made that you're not going to alter treatment regardless of what you see.
A quick comment on the pinhole. There's no doubt that pinhole has a better spatial resolution and it has advantages. By the same token, one has to also deal with the specificity issue. The focal remnants left by the surgeon, typically not appreciated. These focal remnants can be easily misinterpreted by the nuclear medicine, not by the experienced ones, but in the community as nodal metastases, and you could falsely upstage these patients. That's a potential caveat.
Yuri, if I may make a final comment on this one.
Yes.
Yes, but, and I couldn't agree with you more, Cesar, there's a lot of false positive readings. It's interesting, though, with the Korjaikar study of knowing that good surgeons rarely leave behind more than 4. In fact, there's a little spectrum, and you go to 5, 6, 7, it's highly unlikely that it's not locating it, it's the number. And that strongly increases the likelihood. So if I have 7 foci left, and I forget the number of how frequently that was, but I have the data and I can send it. But that's going to drive me to say that's highly likely that that is not due to the surgeon leaving so many focal spots behind. That's most likely due to lymph node metastasis. I stop the process. I go back to the endo. I go back to the surgeon. Let's relook at that ultrasound. How well was it done? Where was it done? Etc. Fine needle aspiration. And we may move from remnant ablation to adjuvant treatment, which does affect our number of millicuries that we give. If an institution, say, I think if I understand Markus, would give 100 millicuries for remnant ablation or adjuvant treatment, or the objectives are combined, he's going to give 100 millicuries, and that won't affect his decision to treat.
Correct.
So number with a pinhole matters.
All right, let's move on, Yuri.
Thank you. I think that we've gone through all chat questions. Seza, I'm turning to you to go over the Q&A questions.
Okay. We have actually one comment made by Dr. Goldsmith that we didn't share this morning, so I'd like to share that first. It says, first, I want to applaud the organization of this meeting and all the presentations. Outstanding. When considering I-131 treatment, we need to stop confusing ablative doses with adjuvant therapy goals, and further to be more attentive to adjuvant doses. To go steep further, it will seem that we also should be more frequently determining tumor dosimetry, even if performed retrospectively. If the absorbed dose is insufficient, a pretreatment assessment focused TKI should be performed. Anybody wants to comment on this comment?
I've seen that comment.
No, go ahead.
Sorry. I've seen that comment in the chat, and I wanted to applaud. I think it's an excellent approach, and yes, I fully agree.
I mean, I definitely agree with the idea that we have to divide up ablation and adjuvant therapy and stuff. As far as like lesional dosimetry and the ability of doing that and doing that retrospectively, I defer to my colleagues like Markus and Doug and Seza on the feasibility of that. I just know, or my impression, I should say, is that that's not necessarily widely available or widely done.
Well,
It's not done at all. How do we logistically deal with this? This is an important issue. Mike?
Years ago, FDG PET scans weren't widely available either. I mean, why are we treating known distant mets without knowing the lesional dosimetry? But that should be unacceptable. We should say we know how to do this. I-124, I mean, the Mayo Clinic's been doing it for how long with regions of interest and CT scans to do volume, and Harry Maxim did them in the 1970s. So it's not like we can't do that. Obviously, I-124 PET would be like the gold standard, right? I mean, you can do lesion dosimetry with that. But I think we really just have to say as a group, when we're treating distant metastasis or evaluating people, as Stan said in his comment, those bone, if you have a bone met that's barely concentrating radioactive iodine, yeah, you can get a picture of it, but we know that's not going to be effective. Why wait to do a redifferentiation until 3 treatments after it fails? So, I mean, I really think as a group, particularly in that treatment of known disease, we have got to move toward lesion dosimetry and get away from just trying to figure out what's the maximum administered activity we have.
I was referring to TKI option. That is more difficult. Of course, dosimetry, we all agree that when it's indicated, there shouldn't be any second thoughts. But TKI is extremely difficult. There's no TKI, and there's no MEK inhibitor or BRAF inhibitor approved for differentiated thyroid cancer.
No, but that doesn't mean you can't use it though. So we do this routinely at MD Anderson. So we put patients who have a BRAF mutation on BRAF inhibitors and give them radioiodine when they have distant disease. And they usually have failed radioiodine already when they've come to us. So if we feel like they didn't really respond to radioiodine, they didn't take up any radioiodine, then we do this. I usually kind of wait until the patient is starting to progress too, though. And maybe that's not the right approach. Maybe it needs to be moved up even earlier.
Correct.
I think Dr. Lassner would like to make a comment.
Yes, please. I'd like to follow up on the discussion regarding the symmetry. I mentioned in my talk that we're part of a multicentric study now, and we're establishing new simple methods to calculate the doses. We don't even know the doses to the remnants and the lymph nodes so far. So this has been established by Glenn Flux, Manu Bardies, and others. And they just calculated the doses, recruited 100 patients. They had 5 scans over a week. And now we will get some numbers, and we're going to share these numbers with you, and then we take it from there. Once you build up such a network, it's doable, like Mike pointed out.
All right, let's move on.
I'd like to make one comment.
Sure.
I couldn't agree with Mike Tuttle more.
Good.
I 100% agree with your comments. And I agree with Markus. The European group with Glenn Flux et al. And Markus, they're way ahead of us. And we are trying to build our infrastructure in the US with the SNMI and building a database, which we have done. We've done the national registry. We've developed that's published, that's online, of places performing dosimetry. And our next step, which we've received a little funding, is to try to literally paraphrase what Glenn Flux and the others are doing in Europe in setting up a network, which he has skillfully set up. This is where we need to move.
And more importantly, if Doug and Markus and I agree, we should stop, because it's not going to stay that way. Well, we should declare a win.
That's no fun. Controversy is good.
All right. Back-to-back 2 questions. First one is, how do you get a false positive for a mutation on FNA? Do you, Yuri?
Rarely. Rarely. I mean, it should be not a very high quality lab. I mean, it is more likely to get a false negative results when FNA is suboptimal, when there is not enough cells, that lesion was not really sampled by FNA. To get a false positive result, it is really rare.
Good. Second, is there a role for metastasectomy for patients with ATC who undergo thyroidectomy and have some response to therapy. What's the MD Anderson experience?
Patients that have a single metastasis, we don't usually operate on those, but we do radiate them. And then we put them on systemic therapy, or sometimes we put them on systemic therapy and then they have one lesion that's progressing and then we just radiate that one lesion. And that has worked very well. So I think taking these patients to surgery, the recovery from it, they're usually older patients. They usually have to stop their systemic therapy. And so I don't usually send them to surgery for to remove a metastasis.
Excellent. Next question is, let me make this bigger. It sounds as though Dr. Cabanillas is a strong advocate for molecular profiling on most, if not all, of her patients. I'd be curious if the other panelists similarly use molecular profiling upfront on all patients, or whether the testing is limited to use of genomic classifiers for indeterminate cytology category.
Well, I just want to clarify, I do not test all my patients. I only test the ones that I'm going to treat with systemic therapy, that I have plans, I think they're going to need systemics, but I don't test them all.
So
Anybody from the panel?
We do the same. I mean, we only test patients who are either going to go to systemic therapies or that we're considering for entry into redifferentiation trials. Otherwise, we don't.
So if I may, I just want to pose, I'm obviously in the minority here, but I'm going to pose this question. So we've been talking about 25 minutes about the scans. Can we do this scan? Can we do this scan and that lesion and this lesion, and we bring the enhancement in here? And it seems like nobody's asking the question, how much does that cost? And what is, what has to be paid for this? And then we are talking about molecular testing that probably cost $3,000 that give you information about 700 genes. And we say, you know what, this is something esoteric. We are not really ready. We are not really interested. Not sure. Let's just think really. Let's think maybe as an advanced society, we are ready to start approaching the patients with advanced disease, that we sequence them all, and we don't wait until they're about to die, and then we, when it's really they have a month to live, we just go and do something. It's too late to sequence. But we sequence tumors early, and we know how to better treat them, how to better follow them, and then eventually, if they develop recurrences or advanced disease, how to treat them, even not waiting for molecular testing. Just a thought for everybody.
So I just want to say to that, I agree with some of that, but the problem is that in 5 years, they're going to have some other test that I'm going to want to do on this patient that I didn't do before because it wasn't available. And now insurance won't pay for the molecular testing to be done again. And so that's the rationale for waiting until I really need it. But I agree that, for prognosis, it is important. I just, I've had the situation where 5 years ago I tested and we only had certain genes that we could test at that time, and now I need more information.
Yeah, if I could weigh in, I mean, I sort of, obviously, Yuri, as you can imagine, I would love to genetically test all my patients because I see things very much the same way in terms of that it does provide you information. But then think about the patients who we usually see in a clinic, in a thyroid cancer clinic. These are patients who have had very high quality surgery, who post-operatively have an undetectable thyroglobulin, who we're probably not going to consider for radioiodine therapy. And I realize that in this panel that would be controversial, but that's our practice. And so in that particular setting, we see very little justification for adding that extra cost because in a way the cat's out of the bag. The patient's already had surgery. It seems to be, in terms of the risk stratification that Mike is advocating for which there's good evidence in terms of continuing risk stratifying based on response to therapy. If the initial response is a favorable one, there's very little benefit that we could see in genotyping at that stage. But when you have recurrences, when you're really considering radioactive iodine therapy, I do find it informative at that stage. Now, you are doing something different with the final aspiration biopsies of patients prior to surgery. and shown clearly that that can discriminate in terms of the extent of surgery that you would recommend based on your findings. So in that setting, I don't find that controversial. I think that's very reasonable. But in the post-operative setting, once we know what the pathological stage is, it's marginal, the value that it would add at that stage, and it's more for a selective subgroup of those patients where you might want to think about it. Now, if we're going to be thinking, and if we could validate that in the setting of adjuvant therapy, we could demonstrate that redifferentiation adds benefit, that would totally change the picture, right? Because now we're saying, okay, we're going to give radioactive iodine not in a conventional way, but in an augmented way. Now, the selumetinib clinical trial, the Astra trial, did not meet its primary objective, so it did not show a benefit. And what I've shown you in the data that I tried to summarize today is that selumetinib is a relatively weak MEK inhibitor. So are we going to be able to get the constituency to do a second approach at this with a better drug and a better sort of approach to doing genotype-specific treatment? At that stage, we would be genotyping a lot earlier. So that would change the picture.
Makes sense. Okay,
We're counting on you, Jim, to get us there.
A quick question. In a young female who wants to get pregnant and is worried about radiation exposure, could you do thyrogen imaging with I-123 instead of I-131 in her yearly follow-up scan? Doug?
Okay, ask that again, because you kept adding on additional operative words. So she wants to get pregnant. Tell me the situation again.
In a young female who wants to get pregnant and is worried about radiation exposure from I-131, could you do I-123 imaging with thyrogen instead of I-131 in a yearly follow-up? I guess it's post thyroidectomy, post radioactive iodine surveillance.
So I'm doing this as a surveillance scan. Correct. 1 year after her next one, and she wants to get pregnant now. How young is she?
Young.
Young.
Wait. I mean, if she's 1 year out from her last I-131 therapy, you know, I almost say it's a cliche, but the general rule is most people say don't get pregnant for a year. If she's a year out and I'm going to do an I-123 scan, I'm not worried about the I-123 and her subsequently getting pregnant shortly thereafter. I mean, I-123 is a short half-life, it's predominantly gamma, et cetera, et cetera. I'm not worried about that if I hear the situation right.
I guess the question is the diagnostic power of I-123 versus I-131. Am I going to miss anything if I did I-123 instead of I-131? One 12 hours, the other one being 8-day half-life.
I believe that I-123 will pick up things that I-131 doesn't, and I-131 will pick up things that I-123 doesn't. And Letha Shankar from NIH at one of our earlier, and Susan Mandel published some of the initial work evaluating I-123 and I-131. They each have advantages and disadvantages to each other.
So let me suggest a very cost-effective follow-up to a young person with low risk and excellent response. It was done last century when Markus and I trained. It was called physical exam. Worked pretty darn well, had 100% survival, a little radiation because they have to fly to New York. So they have that. So, you know, this idea of having to do a yearly whole body scan anymore, not so much anymore.
Well, I would like to make a comment, Yuri.
Go ahead.
I don't think there's many people on the side of the controversy of proposing annual surveillance scans. Now, I have articulated a position that is not documented, and I wanted to do this study. I do think that if you have treated a patient with I-131, not doing a surveillance scan, if you've treated a patient with I-131, I'd like a new baseline scan at 1 year. I've made a therapy. I want to know what the neck looks like so that when that patient comes back and the TG goes up, was the neck clean at the 1 year mark, or was a little remnant tissue left? 15% of the patients of Malik and Schlumberger have activity left, or is there an area of activity that's in a different place than where that tissue was before? It's very inexpensive. It's reasonable to do. And so I believe a baseline scan at 1 year is reasonable, but I don't want people to think, certainly from my standpoint, that I advocate annual surveillance scans like we used to in the 80s.
Mike, or the second, maybe not so inexpensive option, although if you think about the cost of hotels in New York, you know, is to send her tumor for molecular testing. And if it has, you know, low risk signature, her risk of recurrence is 0.1 to 0.3%. So probably she also doesn't have to take radiation pill, you know, for annual scans, you know, as a second alternative.
Markus?
Yes, I agree with Mike. I would skip the scan. Usually I also like to have a baseline scan, but especially in young females, we discuss with them, and if they want to get pregnant, that's top priority. So I wouldn't insist on any scanning at all. But on the other hand, in my opinion, the risk of birth defects is overestimated. I mean, we treated 250 young kids with thyroid cancer from Chernobyl, and we didn't see an increased rate of birth defects. That has to be kept in mind. Of course, all these intervals that are suggested, like half a year, they're based on biology. There are no findings supporting that, and you shouldn't be too cautious there. But in the given situation, I would just skip the scan, have a TG, and fly to New York, get a physical examination. That's all.
Actually, we have a question from a patient. I know, I mean, he approached me, you know, at one of the meetings. I don't know if you don't mind, I can read the question.
Sure.
Dr. Cabanillas and all, I have ETV6 and CRK3 fusion detected by Thyra6 that presented as a 5.1 cm nodule in left lobe with lymph node involvement. Thyroidectomy was performed with central neck dissection. Surgery was 2.5 years ago. Ultrasound still show no change, and TG is undetectable. Post-surgery RAI was recommended, but I opted not to do it. At this point, is there any reason to treat with radioactive iodine, given risk-benefit and possible targeted treatment available for NCRK3 down the road? Thank you.
Sounds like he's done well without radioiodine. So it's 2 years out. This is papillary, right? So I don't think that anything needs to be done at this point. It's good to have the information on the fusion, because in case they're, you know, in case patient develops distant metastatic disease, then, you know, you have a drug to use. If the patient relapses in the neck, then it's a surgical treatment.
Anybody else? Dr. Tuttle, Dr. Fagin, any
I
other
agree.
thoughts?
I agree.
Cool.
All
Okay,
right.
Seza, sorry, continue, please.
That's okay. In a patient with normal thyroid, thyroglobulin level is approximately 20 to 30. Can we use this information to deduce that post-total thyroidectomy and radioactive iodine, if the thyroglobulin is 18, then the mass of metastatic thyroid cancer is about 10 to 20?
Ram.
I think this refers back to the case that we had discussed right before we left for the afternoon lunch and stuff, because there was a TG of 18 and they had a residual node and stuff. I would just say I'm unaware of a accurate nomogram that you can use to use a serum TG and predict the exact amount of grams. Yes, you see people with very high TGs, but it doesn't necessarily correlate. I mean, we all have talked about the tumor can vary and how much thyroglobulin it produces and such. So I would think you could get fooled by this easily, but I don't know if anybody has a different thought.
There is no correlation between thyroglobulin levels and tumor volume. And, yeah.
Oh, I'm sorry. Go ahead, Dr. Fagin.
No, I think the question was about, can you make an assumption about tumor volume based on thyroglobulin level, if I understand it correctly? Yeah. And I don't think the answer is no.
Yeah.
I agree.
Is there
This is
anyone who
why-
does?
This is why I check the thyroglobulin before patients go to surgery, though, because there are patients that do not make thyroglobulin or make very, very little, and they don't have poorly differentiated thyroid cancer. They have a differentiated thyroid cancer. They just don't make a lot of thyroglobulin. And then I know I can't rely on that.
Does anyone else do preoperative thyroglobulin? Am I the only one who doesn't do it?
We don't routinely. A couple of our surgeons are. Part of the reason we don't is it's so hard to teach it to anybody, right? When you do a pre-op thyroglobulin, what you're looking for is somebody that doesn't have it appropriately high. You know, they've got a big mass and the thyroglobulin is 30. So it's not the high value that helps me before surgery. It's one that's kind of inappropriately low. And then everybody asks me, well, what's inappropriately low? How big's the nodule and that sort of stuff. So I find it helpful for me personally, but trying to teach it or do it, or you do it in the setting where there's multinodular goiter or iodine deficiency, you're just not going to see a correlation.
Or Hashimoto's, Mike,
Yeah.
because Hashimoto's increases thyroglobulin.
Yeah,
Yeah,
I only use it as the low value is helpful to me.
yeah, just to illustrate Maria's point is, you know, in the redifferentiation studies that Alan Ho has been doing, you know, where we look more you know, comprehensively at the population as a whole, those you have patients with clear, you know, significant, structurally significant metastatic disease, and you have a number of them that have disproportionately low thyroglobulins, and other that have higher thyroglobulins. The ones that redifferentiate are the ones that have the higher thyroglobulin at baseline. The others are tumors that already are poorly differentiated, and a marker of that is that they have low thyroglobulin levels or disproportionately low for their tumor mass. So you know, so just to illustrate the fact that you cannot associate volume of the tumor with thyroglobulin levels because they differ. And what we discussed earlier in the talks was that you know, we know that BRAF mutant tumors have low thyroglobulin, right? So that's going to be a factor here as well.
Okay. Next question. One of the challenges is determining when surgical intervention for metastases would be most beneficial for the patients. As an example, patients who already had, I guess this is one patient, who had 3 neck surgeries, including a laryngectomy, remaining metastases in manubrium, 2.5 centimeters, and 2 mediastinal lymph nodes. Lesions are avid to radioactive iodine, but not fully responding to radioactive iodine. Thyroglobulin drops to 200s and after radioactive iodine treatment, but returns back to 700s a year later, with stimulated thyroglobulin being 3,500. Question is, should surgical resection be discussed, considering the morbidity associated with such intervention, and the patient wants to be aggressive, hence a laryngectomy? That's how the question ends. In the beginning, it already said the patient had laryngectomy, but I guess in essence, the question is asking how far aggressive surgical interventions do you do if the tumor is partially responding and then stop responding, or come back as measured by thyroglobulin? How do you manage these complicated cases?
Well, I'll start with the structural incomplete and then let Markus and Doug talk about treating and retreating. So when we see these lymph node metastasis or bone metastasis or wherever, lung metastasis, there's a checklist of 5 things that we think about. What's the size, which is tumor volume? How quickly are they changing, which is doubling time? What's the location? Are they symptomatic in patient preference? So size, location, rate of change, symptomatic, patient preference. It's like a pilot's checklist. If you go through that, most of the time, that'll tell you whether it's time to do surgery or watch, or begin a systemic therapy, or watch or do external beam radiation. Obviously, it gets more complicated when you've got multiple decisions in multiple places. But in terms of knowing when to operate or not to operate on any individual lesion, a handle on those 5 things will let you take the first step and know whether it's truly an active surveillance piece or you're going to have to do something.
What would you do in this particular patient? The patient wants aggressive treatment, previously heavily treated surgically, and extent of disease is significant, requiring a re-excision of the airway, re-excision of, or new excision of manubrium.
I mean, there's no way to answer that on a panel discussion, right? That's an hour and a half of me looking at their CT scans, and honestly, when did they get their last dose of radioactive iodine? Did it shrink and then respond back up, or did it grow straight through that? What are the morbidities associated with my surgery? Memorial says everything is technically surgically resectable, right? We can take everything out, but right. Is that a good idea? And setting that with realistic expectations. You know, if this is a rapidly growing tumor and I'm going to take your left arm off and you're going to have distant mets again in 3 months, that doesn't make any sense. So those kind of questions are challenging. They're impossible to ask like on a panel discussion, but trying to put that into context the way Maria was talking about on the anaplastics, right? What are you going to do in what sequence and when do you operate and that sort of stuff? So, you know, it just has to be your best understanding of the natural history of their disease and how your treatments have altered that natural history, if at all.
This is where tumor board comes in helpful, where you have all your partners. And I mean, because XRT could be something else, but I agree with Mike, and you can't, this is impossible to answer too. I mean, you need all that information and input from all your colleagues.
And before Yuri says it, molecular testing.
Yes, molecular testing.
Thank you, Maria.
Yeah, I want to agree with Yuri. Even I would order molecular testing there.
Definitely.
As you point out, it's 3 operations too late, but I would order the molecular testing.
Excellent. Okay, the next question. Doesn't pre-therapy dosimetry overestimate the dose absorbed by the tumor? Since I-131 is cytotoxic, the cell will be exposed to ionizing radiation, and the residence time will be less. Do you adjust for that factor?
I can take that, or Markus can. First of all, most dosimetry right now is whole body dosimetry, so it's not tumor dosimetry. Now, what Markus is talking about is Europe is ahead with Glenn Flux and Handscheid and other physicists with I-120, actually using I-123. So he can better address that. I know what they're doing, but I don't know the results. But in regard to the typical dosimetry in the US, it's 99.99% whole body dosimetry. We're not looking at tumor. Now, if one asks the question, are we overdosing with the whole body? There's 2 answers to that. Number one, when one goes back to, it's called the Marinelli formula, which is what Benoit and Leeper started in Memorial, or you look at the MERD, that will underestimate the amount of activity that can be given. I can go through the reasons of the formula, but it's built such that it is protective and underestimates delivering 200 rads to the bone marrow, or in the case of MERD, 300 rads to the bone marrow. And we also now have, since Rahl in 1956 published his first article, we now have, what is that, almost 75 years of dosimetry being performed, at least 60 with Benoit and Leeper, and that Marinelli formula and now the MERD do very well in not overestimating the dose to the bone marrow.
I guess part of the question is this, as if I understand this correctly,
lesion.
This is partly related to a stunning effect. If there is a stunning effect from the dosimetric round, would you adjust the decreased uptake, potential decreased uptake due to potential decreased uptake, the subsequent dose?
I was going to say, we're looking at that right now with Steve Larson, and we're doing lesional dosimetry on I-124 PET,
right,
and then repeating the lesional dosimetry on the therapeutic dose, where we can ask, you know, was there an effect of the at least this time I-124, because it's on the I-124, and what we're predicting to be on the lesional dosimetry, is that what we're really seeing? So it'll be a small subgroup of our I-124, but we're trying to answer that exact thing. What you predict on I-124, is that what you really get on the I-131 therapy?
Once you're dealing with dosimetry in general, it's not an exact science. You have to deal with a certain margin of error, of course. And one of the influencing factor is the volume of the lesion. And sometimes even the volume is hard to predict. So if you don't have like a circumscript tumor lesion, you may easily run into 30 to 50% deviation there. So it's not an exact number you end up with, but especially in whole body dissymmetry, you know what the maximum would be, and that's easy to apply. And lesion dissymmetry is even more complicated, but I think we will find, and we're working on the tools to help with that. And to answer the question also from my perspective, we don't correct for that, and we use a very small amount of iodine 131 for the whole body dissymmetry. You only need like 10 MBQ. That's not a lot, so stunning is not an issue in this regard. If you go for iodine 124, iodine 123, which has the problem of you can't do like a week-long dissymmetry, then you don't have the problem at all. But I'd be interested in the findings of the memorial people.
We have additional questions submitted through the chat.
Go ahead.
Is there not now a shortage of higher dose iodine 123 capsules for use with recombinant TSH stimulated ablation protocols? ? Anazawa Health Tampa is no longer producing this, and this has caused us to alter upfront approach in many cases. Is anyone else experiencing this?
Yes.
Yes.
We used to be able to get up to 10 millicuries in one capsule. It doesn't exist anymore.
I know there was a problem with Oak Ridge, and the one of their generators was down to make stuff. But I thought that had rectified. Does anybody know why that is? And the Oak Ridge thing was back in the fall, like August, September, October, around then. Then we were really having trouble. And when COVID first hit, we were having trouble with getting things delivered as well. But I hadn't heard about the amount, but
the 2 to 3 millicurie doses of I-123 are still out there, right? At least as of Tuesday, because that's what we're using. We haven't had any trouble with. Is it just the higher dose, Doug? Is that what the issue is?
Well, is yours coming in 1 capsule or 2 capsules or 10 capsules?
1 capsule, I think, Doug.
Yeah,
But
I'd have to recheck myself. We had problems that they were starting to send us 10 and 12 and more capsules. Now, whether that's been resolved or not, which is an additional problem, and then they're also jacking the price on it. So there are some logisticals, but I haven't checked that recently.
So they could be doing that and me not know that, because they would just do that behind the scenes for me.
Yeah.
if somebody responded, they get 5 to 10 capsules.
Esma Akin from GW. She's a nuke med physician saying they're 5 to 10 right now. Thank you, Esma. Hello.
Seza, do you have any other questions?
I don't have anything in my queue.
Perhaps I can ask, take a liberty to ask the panelists the questions that perhaps can be answered by Maria, Jim, or anybody else on the panel. What are the current data and trials on using for fusion positive cancers, dedifferentiated cancers, to use inhibitors for redifferentiation and probably re-expression of iodine avidity, if any?
I don't know of any for fusions. I don't know if others do, but on our neoadjuvant selpercatinib for RET fusions and RET mutations, of course, but for the differentiated thyroid cancer patients, we are allowing for them to get radioiodine while they're on the RET inhibitor. But of course, we won't know whether they were refractory, right? Because this would be their first radioiodine. So I don't think that really answers any questions about radioiodine, about redifferentiation with these, with the selective inhibitors of fusions.
There are case reports. I mentioned Lionel Goussin. He was formerly in my lab, and he. I'm sorry. This is in review. But anyway, there are some case reports that have been reported, and also there's a clinical trial proposed for ITOG on using selpercatinib for RET mutant, thyroid cancers for redifferentiation. So there's early indications from case reports. I think there was also one from Korea, and there's an interest in doing clinical trials.
We had a patient, a young child, about 10 years old, with miliary spread in the lungs, and there was a discussion, and the patient had RET PTC1 fusion, and there was a discussion. There was a concern about lung toxicity, and there was a question that if maybe using a combination of RET inhibitors would somehow sensitize it to radioactive iodine, this could be treated with a lower dose, something like that. I don't know. There was no consensus at that time, but if you have any comments.
But those patients usually take up radioactive iodine very well,
Yeah.
right? So I don't know what you gain by giving a selective RET inhibitor. You might actually introduce more toxicity. I would be nervous about that. And then also just, these drugs are not without their side effects too. So you're introducing more side effects just from the drug.
Markus, you want to speak about the kids? Markus has treated more, young kids and stuff. In terms of toxicity in the lungs, Markus, how often did you see that, like in the Chernobyl kids and stuff?
It was a problem with the Chernobyl kids, but these kids have been pre-treated with bleomycin, the chemotherapy agent, which is toxic by itself, and that was part of the trouble. And we also saw a few patients, I have to confess, when we started the Symmetry, we were treating them heavily, and I remember a handful of cases with serious problems afterwards. So it's always a balance, and we learn from it.
I mean, wouldn't you be able to, wouldn't it make sense in a setting such as that one, if we are going to pre-treat with a RET kinase inhibitor, to actually do a dosimetry and estimate what your lung dose will be before you treat and adjust the dose accordingly, right? So you'll be able to use a lower dose. That will mean that there'll be a decrease in total body radiation, but you can essentially make a decision on the dose based on dosimetry, and it is a lesional dosimetry to the lung, right? That would be the approach in my view.
But the lesional dosimetry in the lung, especially in kids, is quite tricky because they're very tiny. So you don't know exactly.
You don't have volume.
You need to take the whole organ. You don't know what's pathologic or what is normal tissue. That's quite tricky.
But you could use whole body and blood dosimetry, right? The 48-hour general retention, because if that drug worked, then your maximum tolerable dose would be lower, right?
That's the best surrogate we have, yes.
Yeah, I mean, it's not perfect, but yeah, on a kid like that, I would be worried about treating them without, regardless, treating them without that whole body dosimetry.
Right.
Well,
I have one last question. Well, two last questions. Thyroglobulin measurement is sensitive when TSH is over 30. Do you expect it to rise beyond that level, or does it plateau? If follow-up thyroglobulin levels are obtained at different TSH levels, can they be compared? Both TSH are over 30, of course.
Yeah, I mean, okay, so we got 2 minutes because I'm going to dinner. So the thyroglobulin is totally dependent on TSH. So if you got TSH different values, thyroglobulin values will be different values. We all sort of judge it. Is it a little bit more, a little bit less?
So it doesn't max out.
Yeah, I don't know like anybody's data that says the TG is a certain amount at 30, a certain amount at 100 or 200. It gets high, so I don't think that really helps me overall.
Who knows? It may plateau. I don't think we know. The other thing is this withdrawal or recombinant human TSH too, because you got a shorter. Recombinant human TSH is usually lower than thyroid hormone withdrawal. The TG.
They often are.
Well, it's 4:58, and I think on behalf of Dr. Gulec and myself, I want to thank all panelists, all presenters today for outstanding presentations, state-of-the-art, really data, for what all you do for your patients, for all teachings that you provided for the audience. We had 100+ delegates yesterday and today. We thanks to them for spending their Friday and Saturday with us. Thanks again, everybody. Stay well, and hopefully see all of you next year at the 5th Miami Symposium. Thank you and good night.
Thank you very much.
Thank you.
Bye.
Bye.
Bye-bye now.